Welcome. In this explainer, we are going to build a really solid clinical framework for when you're faced with a bleeding patient. This is something that demands a clear, step-by-step approach, so let's just dive right in.
Okay, so picture this. Your pager goes off. You're called to see a patient, and they're bleeding. It's a tense situation, right? Your mind starts racing. What labs do I order? Where do I even start? Well, the answer might actually surprise you. It's not about grabbing a bunch of labs right away. Before you even think about looking at a single lab value, the most powerful tool you have is right in front of you. It's the patient's story. The history is what gives you the context for everything else that's going to follow. It's truly the Rosetta Stone for this whole diagnostic puzzle. So, to figure out what's going wrong when someone's bleeding, we first have to understand the absolutely elegant system that's designed to stop it, and that's hemostasis. Here, we've got two different ways to think about coagulation. On the left, you see the cell-based model. Think of this as what's really happening in the body, on the surface of our cells. It's complex, like a bustling city. But on the right, we have the classic waterfall model. Now, this is a simplification, for sure, but it's incredibly useful because it's like a subway map for that city. It maps directly onto the lab tests we order every day. Let's really focus in on this waterfall model. Just burn this Y shape into your brain. The left arm is the intrinsic pathway, and we measure that with the APT. The right arm is the extrinsic pathway, measured by the PT, and they both come together at the bottom in the common pathway. Seriously, understanding this simple diagram is the absolute foundation for making sense of your patient's labs. Okay, so we've got the theory. Now let's see how this all translates into practice when you're actually evaluating a patient. And we're going to stick to our main rule here. History first. These questions are your bread and butter. You have to ask them. Are we talking about small, surface-level bruises and annoying nosebleeds? That should make you think about a platelet problem. Or are we talking about deep, painful bleeds into joints and muscles? That should scream hemophilia. And please, never ever forget to ask about all their medications. And that includes over-the-counter stuff like aspirin and even herbal supplements. So once you have that detailed history, your initial lab workup is actually pretty straightforward. You just need 3 simple tests: a CBC to look at the platelet count, and then your PT and APTT to screen that coagulation cascade we just talked about. See, the history you just took is what's going to let you make sense of these results. All right, now for the really cool part. We can actually use the patterns from these few simple tests to come up with a surprisingly short list of what might be going on. It's kind of like being a detective, right? You're just following the clues to crack the case. Let's look at our first pattern. Let's say the APTT is long, but the PT is totally normal. What does that tell you? It tells you the problem is stuck in that intrinsic pathway, the left arm of our Y. This pattern should immediately make you think about hemophilia A or B. It's classic. Now, let's flip it. What if the PT is the one that's long, but the APTT is normal? Well, now you've got a problem isolated to the extrinsic pathway, the right arm of our Y. And this pattern should point you towards things like liver disease or maybe a vitamin K deficiency. So what if both tests are way off? Well, that tells you the problem is either down in that common pathway, or, more likely, there's some big systemic process that's just chewing up clotting factors from both sides. This is the classic pattern you see in something like DIC, or disseminated intravascular coagulation, where the body is just using up its clotting ability faster than it can produce it. And here it is, all laid out. This table is basically your cheat sheet. It gives you this incredibly powerful framework to go from a simple lab pattern straight to a solid differential diagnosis. Oh, and pay attention to that last row. If the screening labs are normal but your patient is clearly bleeding, you've got to start thinking about platelet issues or maybe a mild von Willebrand disease. So let's say you have that long APTT. You're faced with a big question. Is the patient just missing a factor, or is something in their blood actively blocking a factor? That's where the mixing study is a game changer. Think of it this way. If you add normal plasma and the APTT corrects, great, the patient was just missing something. But if it doesn't correct, that means there's an inhibitor, something in the patient's blood that's blocking the factors in their own plasma and the normal plasma you just added. It's like a wrench in the gears of the whole system. Okay, let's take this diagnostic framework and apply it to some of the real-world congenital bleeding disorders you're definitely going to encounter. Hemophilia A and B are just perfect examples of that prolonged APTT with a normal PT. What's wild is that clinically, you absolutely cannot tell them apart. They both show up with those hallmark deep joint and muscle bleeds. The only way you can differentiate them is by getting specific factor levels for factor 8 and factor 9. Now, here's a statistic you absolutely have to know. Up to a quarter, 1 in 4, patients with severe hemophilia A will eventually develop antibodies or inhibitors against the factor replacement therapy we give them. This is a massive treatment complication that makes managing their bleed so much harder. Okay, next up is von Willebrand disease. This is the single most common inherited bleeding disorder out there. But unlike hemophilia, this one usually causes that mucosal type of bleeding, nosebleeds, heavy periods, easy bruising. The labs can be a little tricky because one of the jobs of von Willebrand factor is to protect factor VIII. So if VWF is low, factor VIII might get chewed up, leading to a prolonged APTT. But in milder cases, the APTT can be totally normal, which can really throw you off. Now let's switch gears and talk about bleeding disorders that people aren't born with, but that can actually develop later in life.
DIC is one of the scariest coagulopathies we deal with. The key word to remember here is consumption. Some huge trigger, like overwhelming sepsis, causes the body to start throwing tiny clots absolutely everywhere. This uses up all the platelets and clotting factors. And that's what leads to the crazy paradox of DIC. The patient is both clotting and bleeding all at the same time.
Now, both severe liver disease and DIC can give you a prolonged PT and APT. So how on earth do you tell them apart? Well, here's a really useful pearl. Check the factor VIII level. See, most clotting factors are made in the liver, but factor VIII is one of the exceptions. So in liver disease, its level is often normal or even high. But in DIC, it gets consumed along with everything else, so its level will be low. It's a great tiebreaker.
Hey, remember our mixing study? This is where it's so incredibly useful. Acquired hemophilia is caused by an autoantibody that specifically attacks factor VIII. So when you do a mixing study, that antibody in the patient's plasma just gobbles up the normal factor VIII you added from the control plasma, the APTD stays long, and that tells you, clear as day, that there's an inhibitor at play. And that brings us full circle, right back to where we started this whole conversation. After all the pathways, all the labs, all the specific diseases, the main principle doesn't change. The labs are vital, of course, but they are pretty much meaningless without the context that only a good, thorough clinical history can give you. So always start with your patient's story. So the next time you're standing in front of a patient who's bleeding, how are you going to integrate both the hard data and their personal story to solve the puzzle? Remember, the labs give you the what, but it's the history that always gives you the why.